We are going live with this program. So, good evening and good morning to all of one who has joined on this very essential and vital topic on extensor and flexor tendon rehabilitation. I think I said it's vital because many things are keeps updating. Many protocols have been changed, and all those whichever protocol have been changed are for the benefit of the patient and for the quicker recovery. With this brief introduction, I welcome Dr. Shrikant, Dr. Chauhan, Dr. Kristen, and Juliana. Of course, she could not attend live, but she has a pre-recorded presentation for this evening webinar. Special thanks to Dr. Shrikant who organized this event with a holistic
teaching, 30 years of research experience. He has been instrumental in developing upper extremity rehabilitation related programs across Canada in different eminent centers. And prominent of them is at the Roth-McFarlane Hand and Upper Limb Center in
slip that is advancing towards its insertion on the middle phalanx. Here you have two lateral bands, and the extensor expansion is right here, extensor hood. You can see there are multiple fibers which are crossing each other in different directions. So very interestingly, if you look at the intraosseous muscle or intrinsic muscle that is contributing to the extensor system, have specific amount of orientation in terms of the fiber orientation, so to speak. So there are some fibers that are oblique, there are some fibers that are transverse and so on, and each of these fibers have different roles to play. Unfortunately, I will not have enough time to discuss all these fibers in details. However, I'm going to demonstrate the fact that how do these fibers really work in order for the fingers to extend from fully flexed position to fully extended position. So this is an enlarged view to show you the orientation of the extensor system so that we can keep that in mind, that once the central slip is gone, then the lateral bands are influenced by the intrinsics. So these fibers which are obliquely placed then become vertically oriented, so that vertical orientation causes the volar translation of the lateral bands below the axis of rotation at the PIP joint. But anyway, if we look at the extensor digitorum communis, we know that it's a tendon that splits into three slips. This is the central slip. These are to your lateral bands, and these lateral bands advance towards its insertion, connecting to the distal phalanx. You can see that these extensor digitorum communis is dorsal to the anatomical axis of rotation at the metacarpophalangeal joint as well as interphalangeal joint. Looking at the placement of extensor digitorum communis, we can very well say that the extensor digitorum communis provides us with a linear force and attempting to give an extension of the extensor system is. So excessive extension of the PIP joint is controlled by the volar plate. If you take the volar plate off, then there'll be an unrestricted excursion of the central slip. We very well know that upon losing the volar plate, the middle phalanx will have a tendency to ride in hyperextension, and therefore it will produce a secondary swan neck deformity. So volar plate therefore prevents excessive excursion of the central slip, and volar plate's presence is definitely important because it provides us with the dynamics of equilibrium. So what is exactly a dynamics of equilibrium? So dynamics of equilibrium is when the extensor digitorum communis and intrinsic act together, the forces of extensor system, whether it's dorsal or oblique, they produce a torque, especially at the distal phalanx, proximal phalanx, as well as the metacarpal, causing the extensor system to produce a force that is passing through the axis of rotation at the distal phalanx, middle phalanx, as well as metacarpal, and then this is providing a dynamics of equilibrium. In other words, when a finger is fully straight, the forces of extensor tendon or extensor apparatus, along with the flexor digitorum profundus and flexor digitorum superficialis, passes through the center of each and every curvature of the metacarpal head, proximal pharyngeal head, as well as middle pharyngeal head. So this is something which we have to keep in mind whenever we are discussing the disturbances occurred as a result of terminal tendon rupture or central tendon rupture. So I had an opportunity to perform quite a few dissections on cadavers, and that was with Dr. Roth-McFarlane, and we identified that when we draw the intrinsic and extrinsic mechanism together, we see that it's not a single diamond system, but it's a double diamond system. So the blue structure that you see is the Extensor Digitorum communis, splitting into 3 slips, and these slips, especially the lateral bands, insert on a distal phalanx, whereas intrinsics connect to the medial band as well as the lateral band, and these lateral bands are now called as the conjoined lateral band. So you can very well see that it's a diamond in the diamond, so it's a double diamond system, truly speaking. So let's look at mechanism of digital extension. So when we start motion from a fully flexed position to fully extended position, we have distal interphalangeal joint. So this is the mechanism of extension, which is much more complex than mechanism of flexion, so to speak. So therefore, it is very important for us to look at how the person is performing his extension from a fully flexed position. So let's look at zone 1 and zone 2 injuries. We know that they are responsible for producing a deformity, what is called as a mallet finger deformity. So mallet finger deformity, therefore, is as a result of detachment of the terminal tendon. So it's a high energy impact that causes abrupt flexion of the distal phalanx, as you can see right here. And as a result of abrupt flexion force at the distal phalanx, we may see either avulsion or rupture of the terminal tendon. Or it could be as a result of laceration of the terminal tendon or laceration of single or both lateral bands if the transection is somewhat proximal. So most common injury is rupture and avulsion of the terminal tendon. So you may have type 1 injury based on Doyle's classification. The injury of the mallet finger has been divided into 4 different categories. Type 1 is a closed injury, which is with or without a small avulsion fracture. The type 2 is an open tendon injury caused by a laceration at or around the distal interphalangeal joint. Or type 3 is also an open injury which causes abrasion of the soft tissue structures or even loss of skin and tendon at the distal phalanx. And type 4 is a mallet finger crush fracture, where you have a complete physical separation of the fragments dorsally and the parent fragment that is getting subluxed in a volar direction because of the pull of the flexor digitorum profundus. So these are the 4 types of Doyle's classification that we may often see in a clinical setting. So from the management point of view, as described by Doyle, closed injuries often are managed by splinting, or some closed injuries require surgical intervention, especially those where there is an inadequate management that was done to these injuries, so to speak, and then the patients have gone into a fixed flexion deformity of the distal phalanx. So in those situations, these closed injuries require surgical intervention. And then open injuries must be managed by surgical intervention, undoubtedly. So if you do a literature search, you will come across a paper which is a blinded, prospective, randomized clinical trial comparing volar, dorsal, and custom thermoplastic splinting in the treatment of acute mallet finger. So very interestingly, these authors compared 3 different types of splinting devices to identify which one works the best, and they came to a conclusion that the mean radiographic lag differences were 16.2 degrees, so to speak. So in other words, patients ended up having 16 degrees of extensor lag at the distal phalanx, which was quite significant in terms of the extensor lag that the patient showed. So having looked at some of these managements, we thought that probably we must change the protocol of extensor or change the protocol of mallet finger deformity or mallet finger injury in order for us to maintain good position of the terminal tendon in close proximity with the distal phalanx, and we should have a better healing or better union of all those structures distally, because otherwise the patients will have a DIP joint extensor lag, and we know that the DIP joint extensor lag will always get converted into a secondary swan neck deformity. So the traditional management that is described in the literature includes splinting of the DIP joint somewhere between 4 to 6 weeks, and then gradually weaning of the splint over next 4 to 6 weeks period of time, depending on the symptoms. So we have seen that the management often is as a result of fitting these patients with the stack splint. So looking at some of these injuries, we identified that probably the DIP joint splinting itself is not adequate enough in restoring the connectivity between the ruptured terminal tendon here or an avulsion fracture. We have to do something else in order to approximate every structure in the close proximity where the trauma is. So in the literature, you'll see a whole slew of different types of splint that have been used to manage mallet finger. I remember after my graduation back in 1971, I started working as a hand therapist, not a hand therapist, but as an occupational therapist at Christian Medical College and Brown Memorial Hospital in Ludhiana, Punjab. And back then we used to position the PIP joint in 90 degrees of flexion and DIP joint in hyperextended position. And we identified that this management caused PIP, severe PIP joint flexion contracture, and patients, even though they had ruptured terminal tendon, they ended up having secondary Buchner deformity. However, looking at the management, the current management that is written in the literature, that splinting the DIP joint alone is not adequate enough in providing justice to the detached terminal tendon here or the avulsion fracture as you see right here. So because the complication of the mallet finger is a secondary swan neck deformity, and it's very important for us to understand why do these patients end up having secondary swan neck deformity. So this is based on Juliana. There's a beautiful chapter on mallet finger in volume 3, and he described this pathomechanics very well. So he identified that upon detachment of the terminal tendon or with avulsion fracture, the terminal extensor tendon recoils proximally. Now you can see that upon retraction of the terminal tendon, your spiral oblique retinacular ligament also retracts proximally. So sudden retraction of spiral oblique retinacular ligament as well as recoiling of the terminal tendon causes detachment of the tendon at the insertion site, and you can now imagine that all the forces of extensors, besides being shared or should have been shared by the 3 joints, they are now no longer shared by the distal phalanx. So ultimately the forces of extensors tendons and forces of the intrinsic tendons are now focused on the PIP joint, causing PIP joint to go into hyperextension. So we can very well see from the pathomechanics point of view, the transmission of intrinsic forces are through the medial band, and transmission of forces through the central slip jointly together causes PIP joint to hyperextend. In this situation, over time, because volar plate is significantly stressed, volar plate becomes somewhat slack or lax. As a result, the dynamics of equilibrium and the PIP joint is completely lost, and patients end up having secondary swan neck deformity. So here, of course, the DIP splinting alone is not doing any justice to the finger. From the management point of view, you can see that the PIP joint is excessively loaded because of the pull of the central slip as well as pull of the medial band, causing PIP joint to hyperextend. And of course, the terminal tendon that is retracted somewhat proximally is now filling up with the gap scar, and this gap scar makes the terminal tendon relatively longer in comparison with the counterpart. As this is a flexor digitorum profundus. The terminal tendon is longer as compared to flexor digitorum profundus, and flexor digitorum profundus being stronger in terms of its muscular force. The extensor and flexor force difference is significantly altered, and therefore the DIP joint falls into flexion, whereas PIP joint rises into hyperextension. So complication, therefore, is a secondary swan neck deformity as a result of deforming forces that are through the medial band as well as the central slip, and then gap scar formation of the terminal tendon at the distal phalanx. So this is the pathomechanics. Now let's look at what will happen if we discuss from the diamond of stack point of view. So here, of course, there is a rupture of the terminal tendon. You can very well see that upon detachment of the terminal tendon, the distal interphalangeal joint is no longer sharing the load of the extensor tendons as well as intrinsic tendon. So the whole entire forces are now passed at the PIP joint, and the PIP joint rides in hyperextension, giving you an increased force at the PIP joint, giving you hyperextension of the PIP joint. This is going to be filled with the gap scar. So you can imagine that the length tension relationship between the extensors and flexors is now significantly disturbed. Flexors being powerful will always take over the extensors, and extensors being weaker will be unable to counterbalance the forces of flexors, and therefore patients will have a secondary swan neck deformity. So how do we manage these patients? We can see that, let's go back this. We manage these patients by using a circumferential cast. This is Orphe cast, the material that we use, or you can use quick cast material. Upon receiving a referral, we look at the x-rays and identify that the PIP joint is already showing a tendency to hyperextend in both these situations. So therefore, it is essential for us to flex the PIP joint by certain degrees and extend the distal phalanx so that you are bringing the fragment in a close proximity with the mother distal phalanx. Whereas here, once you bring the PIP joint in flexion and extend the DIP joint, you're bringing the tendon, Evel's tendon, in a close proximity with the distal phalanx, and therefore you are creating a balancing act between the extensors and flexors, and you're re-establishing the length tension relationship between flexors and extensors. So here, of course, before we fabricate the cast, we use a tape. So we stabilize the DIP joint with an adhesive tape coming from the volar side, extending the distal phalanx, and then bringing it across the proximal phalanx. We'll tape the distal interphalangeal joint as well. And then after we have done that, we'll use the tubing net to cover the skin so that there is no skin maceration with the cast, and then we'll fabricate a cast in a circumferential manner going from the distal to proximal, and then we'll maintain the PIP joint in slight flexion and DIP joint either in neutral and slight hyperextension. So by doing so, of course, we have restored the PIP joint flexion and then DIP joint slight hyperextension, and patients, of course, are sent home with this cast, and then we'll replace the cast on a weekly basis, once every week. So here, of course, upon fabricating the cast, we'll often send these patients for x-rays, and it's important for us to ensure that the PIP joint is kept in flexion, and you are approximating the end very nicely by positioning the PIP joint in flexion and DIP joint in hyperextension. So by doing so, by flexing the PIP joint to about 30 to 40 degrees of flexion and DIP joint either in neutral or slight hyperextension, you are approximating the tendon ends or even the fracture together in order to have a re-establishment of the disturbed segment of the tendon. So going from here on, then we'll bring these patients on a weekly basis. They're given a non-removable circumferential cast or splint, with PIP in 30 to 40 degrees of flexion, DIP joint in slight hyperextension. And when they come back for follow-up 1 week later, we'll allow these patients to perform flexion of the PIP joint ranging from 30 degrees short of full extension to full flexion. However, we'll still maintain the DIP joint in an extended position, and the cast is replaced later on by means of a splint. So then intermediate phase, which is from 4 weeks to 8 weeks period of time, will provide these patients with the finger-based dorsal orthosis, keeping the same PIP and DIP joint position, will allow these patients to perform daily PIP joint range of motion with a short splint. So we are allowing the tendons to glide, especially the superficialis, not the profundus per se, but we are allowing the lateral bands to glide. And the exercises are performed by the patient somewhere between 10 to 15 repetitions on a 2-hour basis. And in a late phase, we'll use the DIP extension orthosis intermittently throughout the day. Patients will carry on with the same repetition of exercises on every 2-week basis. We recommend that patients do not perform resisted flexion for at least 8 weeks period of time. And it's essential for us to still use the nighttime orthosis to the same position that I described for additional or until 12 weeks period of time from this time on. So looking at our results, we have seen that by placing the PIP joint in slight flexion and DIP joint in somewhat extension or hyperextension, we have re-established the orientation of the terminal tendon or Eval's fracture nicely. The patients have shown great clinical union, and of course, patients have had greater range of motion of the PIP as well as DIP joint without them having secondary Schwanneck deformity. So this is the same patient, as you can see. The terminal tendon detachment, the flexion is great. And this is an Eval's fracture showing full extension of the index finger and, of course, full flexion without having any Schwanneck tendency of the PIP joint. So now let's look at zone 3 and zone 4, which produces Boutonniere deformity. So we know that the common cause of Boutonniere deformity is the central slip rupture. Or you may also have a dorsal lip fracture, as you see right here, or you may have a big chunk of middle phalanx fracture dorsally that will also lead to a Boutonniere deformity. So we know that upon central slip avulsion or laceration, the lateral bands will always have a tendency to fall volar to the anatomical axis of rotation at PIP joint. And of course, because of the lateral band still connected to the distal phalanx, the distal phalanx has a tendency to ride in hyperextension. So from the mechanical point of view, we can see that upon detachment of the central slip, the lateral bands are pulled volar to the anatomical axis of rotation because of the pull of the intrinsic. If you look at those orientation of those fibers, we can see that instead of them having obliquely oriented, they are now vertically oriented. And this vertical orientation of the extensor, intrinsic extensors, we know that they are going to pull the lateral bands volar to the anatomical axis of rotation. And as the person starts to activate finger extension, because the lateral bands are connected to the distal phalanx ride in hyperextension. And as the person still continues extension of the finger, the metacarpophalangeal joint will ride in hyperextension. So in other words, the detachment of the central slip is going to produce hyperextension of the metacarpophalangeal joint as well as hyperextension of the distal interphalangeal joint. The greater the hyperextension at the metacarpophalangeal joint, the greater the volar translation you're going to see with the lateral bands here. So from the diamond of Stack point of view, upon detachment of the central slip, we know that there is no central control available to initiate PIP joint extension, and therefore, upon activation of the extensor system, we know the metacarpophalangeal joint will ride in hyperextension, the distal phalanx will ride in hyperextension, and jointly together we are going to have greater amount of hyperextension of the DIP and MCP joint whereas PIP joint will fall into greater and greater flexion. So in this situation, because in the intrinsics are attached to the lateral band, the diamond will start to widen. And as the diamond starts to widen, the lateral bands will continuously fall into flexion gradually over time. And then the hyperextension is quite obviously noticeable at the metacarpophalangeal joint. So by performing cadaver dissection, we can very well see here that upon detachment of the central slip, as you activate the extensor tendon, your lateral bands fall volar to the anatomical axis of rotation. And then there is hyperextension at the metacarpophalangeal joint and hyperextension at the distal interphalangeal joint. You can see the translation of the lateral bands well below the axis of rotation of the PIP joint. So one must keep in mind that the Boutonniere deformity is a progressive condition. Initially, the middle phalanx is flexed. As you can see right here, the middle phalanx is flexed because of the pull of the flexor digitorum superficialis that is unopposed on the dorsal surface. There is a proximal retraction of the extensor tendon, and this will lead to the lateral bands translation volar to the anatomical axis of rotation gradually over time furthermore, and combined forces will cause the metacarpophalangeal joints to hyperextend. So we can very well see that these Boutonniere deformity is divided into 4 different stages. Stage 1, the PIP joint is passively correctable, it's relatively quite acute. Patients may initially have a loss of 30 degrees or lesser extensor lag at the PIP joint. However, if this is not treated by means of splinting, then there'll be a gradual progressive change that will occur at the PIP joint because the PIP joint is sitting in flex position for lengthier periods of time. So as a result, we can very well imagine that the volar plate may start showing changes, adaptive changes because of the finger's inability to extend completely. So volar plate will become tight. Your accessory collateral ligament will start to tighten and they'll become tight. And at this stage, the stage 2, of course, passively PIP joint may show some limited extension at the PIP joint. It's quite likely because the oblique retinacular ligament is somewhat slack. The flexed PIP joint, the oblique retinacular ligament may start to become tight over time. And in stage 3, the oblique retinacular ligament, volar plate tightness, accessory collateral ligament tightness, tightness of the transverse retinacular ligament will start to become tighter over time. And then finally, the patient will end up in stage 4, where you have multiple changes that have occurred at the PIP joint, multiple changes that have occurred at the distal interphalangeal joint, and some changes have occurred at the metacarpophalangeal joint. So in stage 3, as if it is not managed by means of therapeutic intervention, then they'll progress to stage 4 very quickly over time. We know that the PIP joints are notorious for forming PIP joint flexion contracture. And therefore, PIP joint flexion contracture in such situation is as a result of volar plate tightness, accessory collateral ligament tightness, your oblique retinacular ligament tightness, and of course, certain other changes that we would see is the transverse retinacular ligament tightness, and eventually over time, because the PIP joint is flexed, having a serious PIP joint flexion contracture and DIP joint is hyperextended, you're going to have a dorsal joint capsular changes at the distal phalanx. So your dorsal joint capsule of the distal phalanx is tight, oblique retinacular ligament is tight, enabling passive flexion of the distal phalanx in relation to the middle phalanx, and you have absolutely no ability to passively extend the PIP joint whatsoever. So stage 4, especially, you'll see that the contractures of volar plate, collateral ligaments, retinacular ligaments, and joint capsule at the PIP joint. The DIP joint extension and PIP joint flexion contractures are quite evident. And some PIP joint flexion may be possible if patients have not had any articular changes that have occurred as a result of joint compressive force. So in this situation, there is a massive contraction of the PIP joint, dorsal capsular tightness of the distal phalanx, and over time, because the MCP joint is in a hyperextended position, it's quite likely you may have a dorsal capsular tightness at the metacarpophalangeal joint. Eventually, we know that the collateral ligaments of the metacarpophalangeal joint are maximally taut when the MCP joint is flexed. But if the MCP joint is sitting in a hyperextended position, you will have an adaptive change at the collateral ligament at the metacarpophalangeal joint, and you may notice that flexion of the metacarpophalangeal joint may become problematic eventually because of the position of the PIP and DIP joint. So in this situation, you'll see that you have absolutely no ability or capability of extending the PIP joint whatsoever. Your DIP joint is also stiffer, which will lead to number of adaptive changes at the soft tissue level, and eventually you'll have a massive PIP joint flexion contracture with degenerative changes that have occurred at the proximal interphalangeal level, and eventually you'll see that they may fall. There's no stage 5, however, reported in the literature, but it's very essential for us to add that stage 5 as well, because there is a degeneration of the articular cartilage with massive PIP joint flexion contracture, massive hyperextension tendency with capsular changes at the metacarpophalangeal joint. So these are the changes that are likelihood of happening as a result of central slit rupture that have been not managed or mismanaged from any point of view. So here we have a joint subluxation and articular degeneration, as you see in this classic X-ray of an individual who was not managed properly. So it's very essential for us to evaluate before making a splinting decision for acute Buchner deformity, and the assessment is Elson's test. The moment you have a rupture of the central slip, when you flex the PIP joint and ask person to extend against resistance, patients will have weak or very poor PIP joint extension. And if you ask the person to extend the DIP joint because the central slip is now gone, the lateral bands are still connected to the distal phalanx, patients will have strong DIP joint extension. And diagrammatically here you can very well see that upon rupture of the central slip, all the extensor forces are transmitted to the distal phalanx. So patients will have a strong DIP joint extension, but they'll have a weak PIP joint extension. But when everything is intact, when your extensor tendons are intact, the central slip is intact, patients will have a strong extension of the PIP joint on testing, Elson test. They'll have a weak DIP joint because the lateral bands have fallen volar to the anatomical axis of rotation. So here, of course, this is the positive Wilson's test, suggesting that there's a detachment of the terminal tendon, and therefore the lateral bands are producing greater load at the distal phalanx because of its orientation proximal to the anatomical axis of rotation. Now, if we look at the Bouvier test is primarily designed to assess ulnar nerve palsy, but this can be applicable to the assessment of the central slip avulsion. You can see that we know that upon flexing the PIP and CP joint, your extension of the PIP and DIP joint is as a result of proximal excursion of your extensor digitorum communis, even though you have an intraosseous paralysis. So this test is also helpful in order to identify or do a differential diagnosis to see whether patients have attenuation of the central slip, whether the patients have adherent central slip at the PIP joint, or whether they have a volar subluxation of the lateral band. So the test is originally, as I mentioned earlier, that it was designed to look for ulnar nerve injury. So especially if the patients have a claw hand deformity, by flexing the metacarpophalangeal joint, you are increasing the excursion of the extensor digitorum communis that is causing extension of the PIP as well as DIP joint. So Bouvier test, if we look into those details, We know that MCP flexion causes PIP and DIP joint extension because of the load placed at the PIP and DIP joint through central slip as well as the lateral bands. We can see that there is intrinsic paralysis in those situations. Yes, Bouvier test is quite identifiable. By placing the metacarpophalangeal joint in flexion, the lateral bands tighten, causing the dorsal translation of the lateral bands above the anatomical axis of rotation at the PIP joint. So therefore, MCP flexion causes relaxation of the long flexus and intrinsics, and the lateral bands translate dorsally. We can see very well see that on this cadaver dissection that by flexing the metacarpophalangeal joint, the lateral bands translate dorsal to the anatomical axis of rotation. So this is important that we assess for lack of extension of the PIP joint, which could be as a result of gap scar formation at the central slip. If the central slip is remain proximally detached and retracted, so that gap scar formation, especially if you have, then you will see that the lateral bands will be pulled volar to the anatomical axis of rotation because of the vertical fibers that we talked about. Your triangular ligament, which is dorsally placed with the sustained PIP joint in a flex position, your triangular ligament will become attenuated. The transverse retinacular ligament that is attaching to the lateral bands and the PIP joint, they're going to hold the lateral bands volar to the anatomical axis of rotation, and therefore dorsal translation of the lateral band will be just impossible, despite of you attempting to perform Bouvier test for the Boutonniere deformity. So why will PIP extension will have a lag with MCP flex? There's one gap scar formation between the tendon ends. The other cause being the spiral oblique retinacular ligament tightness. The other reason being patients are likelihood of having volar plate and accessory collateral ligament tightness and triangular ligament attenuation or transverse retinacular ligament tightness. So here, of course, we can very well imagine that if there is a gap scar formation, here the central slip is now longer in relation to what it should have been originally, and therefore PIP joint will not extend. If a person has a spiral oblique retinacular ligament tightness, if this is tight, we know that it is going to cause the DIP joint to hyperextend. This is also not going to cause dorsal translation of the lateral band above the joint axis. So these are some of the tests we must perform in order to identify the severity of the Boutonniere deformity. So Boyce introduced the test, which is again the same. It's a test to identify oblique retinacular ligament tightness as well. So from the assessment point of view, upon receiving a referral, we as therapists, we look at the active range of motion of the fingers. You can see that in this situation, the patient absolutely have no active extension of the PIP joint. So here, of course, we can very well identify that the central slip is completely gone. But by performing passive extension and asking a person to hold the finger in extension, he's able to retain extension for certain length of time. This is an acute case. But after a few seconds or few minutes, the finger will start to fall into flexion because the retention of the lateral bands above the anatomical axis of rotation is much difficult to retain, and therefore there'll be gradual translation of the lateral bands volar to the anatomical axis of rotation. So this test suggests that if the person is able to hold the finger for a certain length of time in extended position, but later on cannot, it may suggest that patients may have a triangular ligament attenuation because of the high velocity of force that has affected the finger to go into an abrupt flexion. So how do we test for triangular ligament attenuation? We provide these patients with a small little DIP splint. The DIP joint is flexed by 10 to 15 degrees in flexion, and when the person performs extension, the person relatively has a better extension. So of course, it is obvious that the triangular ligament is attenuated. However, in this situation, we can see that the person has an incomplete extension of the PIP joint. That means that the triangular ligament is not completely at its anatomical length. It's still lacking some degree of retention of the lateral bands above the joint axis, and therefore the person has limited extension of the PIP joint. So there are various tests we can perform looking at the active extension. I've already described this to you, that perform passive flexion and active hold. The patient may be able to retain that extension for a certain length of time. However, it is suggesting that because of the lack of central slip, the retention is obviously not there. The retention of extension, again, is the same repetition of the same video again for a certain length of time, of course, but finger will fall into flexion. And then the other test is to look at Bouvier test by flexing the metacarpophalangeal joint to see how far the PIP joint extends. And then flexing the PIP joint and then performing passive extension, the person will have greater ability to retain the extension of the PIP joint for longer periods of time. And then we also test for spiral oblique retinacular ligament. So we have to compare this with the contralateral side to see whether the contralateral side flexes to the same degree as the affected finger does as well. So based on this, we make a decision to identify what should be the appropriate position of the finger. So this acute case that we saw earlier, we provided him with the hand-based splint by maintaining the MCP joint in about 20 to 30 degrees of flexion, leaving the DIP joint free to flex. And then we used this hand-based splint for 2 weeks period of time. And then later on changed the splint to just PIP-based splint, and then allowed the person to perform DIP joint flexion and extension. The splint is a bit too long, it should be trimmed, however, but my preference is this is the splint, better splint design. As you can see that we can control the DIP joint, especially we can maintain the DIP joint in extended position rather than it starting to go into flexion. So the reason I added this here, we changed to this splint, is because we identified that just by giving patients a simple PIP joint extension splint, we identified that the DIP joint started to have an extensor lag because of the sustained pull of the flexor digitorum profundus. So therefore, this is a most ideal splint design which maintains the PIP joint in neutral. The DIP joint can be strapped when they are not exercising, so DIP joint can be held in neutral. So the caution here is monitor for DIP joint flexion contracture and extensor lag, as this may result into secondary swan neck deformity, especially when the DIP joint is in a flex position. So you want to avoid that totally. So splinting, we keep the MCP joint flex, PIP joint in full extension, MCP joint flex, PIP joint in full extension for 2 weeks period of time, and then PIP joint in full extension with DIP joint free for additional 4 to 6 weeks period of time, and DIP joint is allowed to move, especially actually from inflection to extension. So you can see that same individual by flexing the PIP joint is now, same individual with MCP joint flex is showing greater PIP joint extension, and here, of course, the person is performing DIP joint flexion. And then this is our preference that after 2 weeks, then you place the patient in finger-based splint itself. So why do we keep the MCP joint in flexion? It's because we want to retain the lateral bands above the anatomical axis of rotation. And then, of course, the retention is basically retention of lateral bands dorsally is critical because we want to have a close approximation of the central slip at its insertion point. So why do we leave the DIP joint free? Because by allowing DIP joint to flex, we can maintain flexor digitorum profundus gliding. Secondly, we maintain the anatomical length of the spiral oblique retinacular ligament. We, of course, maintain dorsal translation of the lateral bands. We maintain triangular and transverse retinacular ligament relationship and prevent dorsal dislocation. And then later on, the results are very encouraging. So here, of course, you can see that the person lacks few degrees of extension at the PIP joint, and therefore we can treat that sequentially. So I'm just going to take another 2-3 minutes and conclude my session. So here, of course, it's Don Lalonde's cadaver dissection describing the same method of management as I described to you. However, I do not prefer to use reverse yoke because it's not a safer way of treating these patients following an acute Buchner deformity. So the reason we avoid the yoke splint is because if we allow the patients to move the PIP joint actively with relative motion splinting, it will cause gap scar formation between the terminal ends, and then central controlling arm will be longer and thus will not counterbalance the flexor forces. So the relative motion splint will not work because there's a gap scar formation of the terminal ends. There'll be an attenuation of the triangular ligament. Patients will have a contracture of spiral oblique retinacular ligament. And then the IP joint will have a dorsal capsular tightness eventually. So after repair of the tendon, we can use active PIP joint short arc of range of motion. Will allow DIP joint blocking exercises. However, we must monitor extensor lag and PIP joint flexion contraction. So the central slip repair, if the details are not available, we can use the reverse spinal splint and maximize mobility. We start off with 30-degree short arc of motion with 15-degree increment weekly and use splint for 4 weeks period of time. So this is a relative motion splint in order to maximize excursion of the central slip. As you can see right here, the results are excellent. And the other method of management of central slip repair is by providing these patients with a template splint, allowing them to move the PIP joint to 30 degrees of flexion and gradually increase arc of motion by 15 degrees on a weekly basis. And then the results are excellent. So in conclusion, zone 1 and 2 extensor injuries are quite common. Swan-neck deformity is complication that is associated with mallet finger, we know that. And Swan-neck, once established, is difficult to treat non-surgically, and therefore we must have an understanding of the deforming force. So zone 3 and zone 4 injuries are quite common. They produce Buchner or pseudo-Buchner deformity. We have to have a thorough evaluation, which is necessary to assess causative factors, and we have to implement corrective therapeutic intervention. Thank you. This is my email address, and then if you have any questions, you can send those questions to me. And happy Independence Day, India, that is tomorrow. Thank you very much. Thank you. Sorry I went a bit longer because I thought I'll add some additional stuff at a later stage.
Thank you, Dr. Shrikant. I mean, it was very exhaustive and very informative, very useful. You took all aspects of zone 1, zone 3, which is very essential for hand surgeons. I think Dr. Stone will take forth.
Thank you.
Thank you, Shrikant sir. So we'll have the Q&A session at the end of the next presentation. So I have the pleasure in presenting to you our next speaker, Kristen McDonald. Kristen graduated in MS in Occupational Therapy in the year 2010 from University of Alberta. She completed her fellowship in hand therapy through Chinchalkar Hand Therapy Fellowship at Roth-McFarlane Hand and Upper Limb Center in 2014. And since then, she is working in the same center. Her area of work, as well as publications, has been in static linear traction for fracture management, digital biomechanics, and arthritis management with orthotic intervention. So with that introduction, I have the pleasure in presenting to you Kristen McDonald. Yes, Kristen, you can start off.
Thank you for that introduction. Just get this started here.
Perfect.
So, sorry. Good morning, and it is morning here in Canada where I am. As stated, my name is Kristen McDonald. I'm an occupational therapist with the Roth-McFarlane Hand and Upper Limb Center in London, Ontario. I'll be speaking today on Zone 5, Extensor Tendon Management, specifically with the use of the ICAM, or the Immediate Controlled Active Motion Approach. And I appreciate the opportunity to be involved today. Firstly, given anatomy and physiology informs management of injuries, we will briefly discuss the unique characteristics of extensor tendon mechanisms within Zone 5 and 6, being the level of the MCP joint as well as the dorsum of the hand. As we know, in this region, the single muscle unit of EDC is tendinous and divided into 4 tendons inserting into each digit, as well as the independent tendons of extensor indicis proprius, as well as extensor digiti minimi, which are oriented ulnar to the EDC tendons, acting on the index and small fingers respectively. However, as illustrated in cadaveric dissections, for example, that conducted by von Schroeder and colleagues in 1995, there is significant variability within the extensor tendon anatomy itself, with the most common presentation being a single EIP, single EDC to the index, single EDC to middle, double EDC to ring, absent EDC to small, and double EDM, with a multitude of other variations as well. This is demonstrated in the photo to the right, and that is from von Schroeder's paper. The greatest variability involves the ulnar aspect of the hand. We also know that biomechanical studies have indicated an ulnar pull of EDC given its lateral origin. An excursion in zone 5 and 6 has been measured at 11 to 16 millimeters. An important tendon supporting structure of zone 5 specifically is the sagittal band. We know the sagittal band is a key structure in the pathomechanics of digital extension. The sagittal band is continuous with the volar plate and deep transverse metacarpal ligaments and acts to stabilize the extensor tendon centrally at the MP joint, as well as assist with MP extension, prevent bowstringing, and limit excessive extensor excursion. While we are speaking of zones 5 specifically, the juncture tendon of zone 6 are an important tendon supporting structure to also consider. These interconnections of adjacent tendons, which are oblique and transversely oriented, act to transmit loads, prevent radial subluxation of the extensor tendon in the event of an ulnar sagittal band rupture, reduce load on the sagittal bands, and prevent splaying of the tendons with distal excursion. However, we know again the anatomy is variable with respect to interconnections, numbers of slips, robustness, or even their presence. The most common presentation being a juncture tendon between the long and ring, between the ring and small, or EDM, and juncture tendon between the index and middle are either absent or very thin. As such, again, the exact anatomy is unknown. Various rehabilitation approaches have been described for the management of extensor tendons, specifically zone 5. Rehabilitation approaches evolve with advancements in understanding of wound healing, biomechanics, surgical approaches, as well as therapeutic materials available. The ultimate goal is to protect the repair, optimizing outcomes, and minimizing complications. Historically, the standard of practice was to immobilize repairs for 4 to 6 weeks, then initiate range of motion. However, this is associated with high prevalence of adhesions, leading to stiffness, limitations in both digital extension as well as composite flexion, lengthy therapy involvement, and dysfunction, as well as the potential for further surgical interventions, including tenolysis and capsulotomy. Much of extensor tendon management has been extrapolated from our knowledge of flexor tendons, including assumed amount of excursion required to minimize adhesion, which is referenced back to Duran with 3 to 5 millimeters of glide, as well as discoveries in basic science research indicate positive biomechanical effects of tendon healing on improved tensile strength, increased fibronectin concentration, improve cellularity, and decrease associated injury to uninvolved surrounding tissues. This information further supports the benefits of early controlled motion. In the 1980s, there was a shift towards passive extension programs through the use of dynamic orthoses. This approach allows for protected active flexion and passive extension with the use of dynamic components to allow for greater tendon excursion, lessening adhesions and stiffness while still protecting the repair. The dynamic approach has demonstrated to provide good to excellent outcomes. However, they are high profile and cumbersome to the patient, functionally limiting, more involved to fabricate and monitor, and more costly with respect to materials. There is a growing body of literature to indicate it is not entirely necessary and potentially more cautious than needed. In the 1990s, controlled active motion was introduced with a goal of limiting adhesions and preventing joint stiffness. Controlled motion is initiated early postoperatively in a protected manner with the inclusion of an orthosis to immobilize and protect. It has been shown to have good outcomes with near full range of motion, grip strength, and return to work sooner as compared to mobilization. This approach, however, has a greater risk of rupture and requires patient compliance. Between these different approaches, around 12 weeks, there are fairly similar outcomes with respect to range of motion. However, each still has its purpose depending on the case. Our focus today, however, is on the ICAM or immediate controlled active motion regime, where the orthosis is referred to a relative motion extension or yoke orthosis. In 1978, Dr. Merritt experimented with cadavers to simulate zone 5 extensor tendon injuries of the long finger. He discovered that when the MCP was positioned in 25 to 30 degrees extension relative to adjacent digits, there was detensioning of the repair with simulated flexion within the confines of the yoke. He also observed that with the wrist in a neutral position, as shown in the bottom left picture, there was gapping of the tendon with digital flexion within the yoke. However, with the wrist in 20 degrees of extension within the yoke orthosis and simulated digital flexion, there was no gapping of the repair, as can be appreciated in the photo to the bottom right. Dr. Merritt also repeated this approach intraoperatively and depicted to the right side with similar results found. The theory supporting this approach is that given the single motor muscle of EDC, by positioning the injured MCP in relative extension, the force is lessened through the tendon and unloading the repair short of 25 degrees end range flexion. It has also been hypothesized that the juncture tendinum harness extension forces of adjacent fingers and that adjacent digits act as a dynamic assist while unloading the repair. This information has been expanded and is also applied to the EIP and EDM tendons. Minamikawa in 1992 and colleagues assessed extensor tendon gliding as well as tension of repairs in zones 4 to 8. With respect to zone 5 specifically, they demonstrated that with the wrist extended at 30 degrees or greater, there is minimal to no tension with full composite digital flexion and full passive extension of the digits. These findings are consistent with what Dr. Merritt discovered as well. This approach is further supported by another cadaveric study by Sharma and colleagues from 2006, which examined the effectiveness of the relative motion orthosis on zone 6 extensor tendon repairs. Cadavers were affixed to an apparatus as depicted in the picture here, and the tendons were loaded into extension and flexion to mimic full digital motion. The long finger extensor was lacerated in zone 6 and repaired. Results demonstrated the strain on the repair was reduced and there was no gapping with the use of the yoke orthosis, whereas without the yoke, there was strain on the repair and gapping. Important piece to note that the cadaver models were immobilized with the wrist in 25 degrees of extension. Dr. Merritt and his therapy team have applied this technique since the 1980s. Sorry, my picture is kind of in the way. Sorry, Dr. Merritt and his therapy team have applied this technique since the 1980s. However, they initially presented their approach and findings in 1997 at an American Association for Hand Surgery conference. Initially, patients were treated with a relative extension orthosis with the MP in 25 to 30 degrees extension with a gutter splint component with the eyepiece and extension, and a strap connecting the finger component to the wrist component, which was also in 25 to 30 degrees extension. Modifications were made over time to lessen the MP extension angle to 15 to 20 degrees, as well as the wrist component to 20 to 25 degrees of extension as two separate components, and that's shown in the top right here. They've indicated that zones 4 to 7, EDC, EIP, and EDM, including multiple tendon injuries, except if all 6 are affected, were managed with this approach. So again, the image to the right is the final version of the orthosis design. The graph on the bottom indicates variations of finger component based on the injured digit or digits. The double X indicates the injured digit. The single X indicates another digit held in relative extension to balance the yoke. The top image would be for a middle finger injury, and the to the bottom right would be for either an index or a small finger. Sorry. Their regimen has been outlined in 3 phases. Phase 1 being 0 to 3 weeks with the use of the wrist orthosis with the relative extension, yoke orthosis with unrestricted motion of digits within the confines of the splint, as demonstrated in this video. Phase 2, which is 3 to 5 weeks, solely the yoke component is used, unless with heavier use of the hand, then the wrist component is also suggested to be used. And in phase 3, which is 5 to 6 weeks, the yoke component is used solely and discontinued at 6 to 7 weeks. This video demonstrates outcomes of this treatment approach. And yes, it's not the same individual as in the splint earlier, unfortunately. Timelines are based on presentation of range of motion, presence of lag, and are adjusted accordingly. Edema control and scar massage techniques are also employed. They do recommend weekly visits to monitor splint fit and advance the program as appropriate. In 2005, Merritt and Howell published on their outcomes over 20 years of implementation of this technique with 140 patients, zones 4 to 7, simple and complex injuries, including EDC, EIP, and EDM. Their results indicate that the majority regained excellent range of motion of flexion and extension, with most obtaining full motion by 6 weeks, few extension legs, no reported ruptures, and no secondary surgical procedures required. Return to work was on average at 18 days, and typically, on average, 7 weeks of therapy was attended with 8 visits. Interestingly, they did indicate that the type of surgical repair did not have a significant impact on outcomes. However, a delay in initiation of the regime beyond 5 days was more highly associated with unfavorable outcomes. There are many publications since to support these results from across the globe. More recently, there have been publications specific to the management of zone 4 to 6 extensor tendons with solely the use of the hand-based yoke orthosis. There are 7 published approaches with 145 patients from zones 4 to 6, with the majority giving results of excellent to good outcomes with no reports of ruptures. However, a scoping review by Hirth and colleagues in 2016, summarizing these 7 resources, indicate that their largely retrospective chart reviews are variable with respect to timelines for application of orthoses, timeline of patients being followed and discharged, as well as inconsistencies with data collection. Overall, the quality of evidence is considered poor. From my understanding, these cases were largely simple single tendon injuries from zones 4 to 6. For these reasons, further research is warranted and advisable to explore further. It may be prudent to continue with the risk component. To summarize, there are variable criteria in determining the appropriateness of the use of the ICAM regimen. Factors to consider include timelines of repair, as well as initiation of the program, patient understanding and compliance. Caution should be taken with multiple tendons, considering the increased stresses on the remaining digits, as well as the ability to maintain the appropriate positioning of the MPs and relative extension. Perhaps a total of 2 tendons should be safe. Despite good retrospective outcomes with the use of solely the digital yoke orthosis, perhaps again is prudent to continue with the use of the risk component as well, as there does not seem to be a robust amount of research to support the case reviews. Although not discussed today, an interesting topic for further discussion would be Zone 4, which I'm personally interested in delving deeper into, given the biomechanical and anatomical differences in Zone 4 as compared to, say, 5 or 6. Overall, the ICAM has been demonstrated to be an effective approach to management of extensor tendon injuries of Zone 5 with superior outcomes to immobilization and potential benefits over dynamic orthoses and early protective active motion approaches with a low profile orthosis, increased functional use of the hand, earlier return to work, and less intensive therapy. These factors are beneficial to the patient, therapist, and also from a health care cost perspective as well. I'd like to say thank you to the Journal of Hand and Microsurgery and Dr. Jerome for the opportunity to be involved today. Special thank you to Shrikant Chinchalkar for his guidance and sharing knowledge, as well as some patient photos, and to our amazing team at the Roth-McFarlane Hand and Upper Limb Center. And thank you all for your time and attention today.
Thank you, Dr. Kristen, for your amazing and incredible talk. It was really fantastic. As Dr. Shrikant was mentioning, we had a lot of questions, Dr. Shrikant. I don't know how you're going to tackle those questions. Dr. Chauvin will take care of all those questions and he'll moderate the questions.
Yeah, thank you. Thank you both the speakers for that lucid presentation of extensor tendons and all its relevant dynamics. So as we move on to the Q&A session for these two presentations, we request the participants to please keep posting your questions. And we have questions for which we'll read out for the benefit of the participants and for the speakers to dwell on those questions. Yeah. So the first question is, I was told to not put the DIP in hyperextension as it reduces the blood flow and thus slowing the healing. Yes, Shrikant sir. Sir, you are muted, sir.
Oh.
Yeah, we can hear you. Sir, you are muted.
Okay, can you hear me now?
Yeah, perfect.
Okay. So yes, it is true that we do not hyperextend the DIP joint past certain degrees. I would like you to hyperextend your own DIP joint and observe that after a certain point, there is a blanching of the dorsal skin. So when you place the DIP joint in hyperextension, you don't hyperextend completely, but back off to a point where there is a flushing of the skin with immediate flushing. That means that there is an increased blood supply to the dorsal part of the skin. So it's very important for us to look at the position of the DIP joint. It would be 5 degrees in extension, 10 degrees of extension, but not beyond the point where the skin has blanched. So you have to back off a bit in order to position your DIP joint either in neutral or slight hyperextension. I hope I'm answering your question. I think Dr. Jerome, you asked me that question, right? Okay.
Yeah.
So the other question, Sean, is it okay if I read those questions and answer those?
Yeah, perfect.
Okay. So the next question is, what is the assessment test for mallet finger and swan neck deformity? So swan neck deformity is multifactorial. It's not a diagnosis, it is a condition secondary to primary pathology. Especially when we are relating the swan neck deformity to the PIP joint. Especially the PIP joint goes in hyperextension, the DIP joint falls into flexion. So the test is to position the PIP joint in slight flexion and see whether you are able to extend your distal phalanx. If you are able to extend the distal phalanx, that means that the terminal tendon is still intact, right? So because the terminal tendon is still intact, by positioning the PIP joint in flexion, if you are able to extend the DIP joint, that means that the terminal tendon has an ability to create mechanical tension at the distal phalanx so that the distal phalanx can extend. So especially when we are looking at the mallet finger deformity, the terminal tendon is detached, and immediately following detachment of terminal tendon, if the PIP joint has fallen into hyperextension, and by placing the PIP joint in flexion, if you are unable to extend the DIP joint, that is suggestive of terminal tendon disruption or rupture. I hope I'm answering Dr. Jerome's question. The next question is, I learned not to do Elson test anymore as it might rupture some fibers that are still remaining fibers. Yes, that is very true. Now, if you look at the Elson test is basically used for patients who are appearing in the clinic late, at about 3 weeks or 4 weeks post-injury. Not all these patients who have had central slip rupture come to the clinic right away. They think that the PIP joint is sprained. They keep on using ice or maybe hot packs and keep on doing their range of motion. So especially these patients who are coming late to the clinic, that's when you are going to do the Elson test, whereas I've included the other test, for example, where you have a hyperextension of the metacarpophalangeal joint. That's a Bouvier test. If you flex the PIP joint, if the PIP joint extends, which will, especially if it is acute, that means that the central slip is affected, especially when you're asking the person to do all the tests that I described, that ask the person to perform active extension of the PIP joint, blocking the MP joint, and see how they can extend. Look at the SORL test. So you're going to do those tests, including the Bouvier test, but not Elson test unless the patient is coming to you 3 or 4 weeks after an injury. That's when the Elson test is very useful, not before that. Because you may have some partial rupture of the tendon, but not complete. And if you have a partial rupture and if you're pushing the PIP joint in flexion, all these remaining fibers of the central slip may get disturbed or torn, especially when you're trying to do Elson test. So this is something, a point of caution, that you're not going to use Elson test in acute state. Okay. So there's a question, what do you think about using relative motion orthosis for boot nerve? So as you see that I've performed a dissection on cadaver to show that once the terminal central slip is avulsed, and if you give the patient a relative motion splint and ask the person to flex and extend the finger, you'll see that when the person flexes, there is a gap between the central slip and the insertion point. So eventually that gap will fill up with the gap scar. If that fills up with a gap scar, that means that the central controlling arm is deficient in terms of length tension relationship. That means that the gap scar in between the central slip and the insertion point if that gap scar is there, your central slip is longer relative to the flexor forces, and therefore the central slip will be incapable of counteracting against the flexor forces, and therefore the person will have an extensor lag, and that extensor lag will ultimately convert into a pseudo Boutner deformity. So that a Boutner deformity to begin with. Now that the gap scar is causing some amount of feeling, but later on they're going to go into a pseudo Boutner deformity. So therefore, I will never ever use relative motion splinting for acute Boutner deformity. You only have one chance to restore the central controlling arm and its mechanism. If you have lost that, then it's very difficult to re-establish the relationship between extrinsic extensors and intrinsic extensors. And the horses are out of the barns, and you can never re-establish the connectivity on all the intrinsic structures. And then, does the range of motion of the DIP joint into flexion, does it do the stretching of the spiral oblique retinacular ligament? Yes, definitely. Because we know that upon detachment of the central slip, the PIP joint will fall into flexion. And because the PIP joint has fallen into flexion, your oblique retinacular ligament will gradually undergo an adaptive shortening. And as it undergoes adaptive shortening, it is going to cause the DIP joint to hyperextend because of the lateral band and especially the spiral oblique retinacular ligament being volar to the anatomical axis of rotation. If your finger is fully straight, your spiral oblique retinacular ligament has a maximum anatomical length. When the finger is flex, your spiral oblique retinacular ligament is maximally slack. And especially when any structure is kept in a slackened position for longer period of time, there will be an adaptive contracture formation gradually occurring over time. Maybe minor changes will occur gradually over time, and eventually you will see that PIP joint extension and flexion of the DIP joint may become eventually difficult. So the purpose of moving the DIP joint in flexion is to maintain anatomical length of spiral oblique retinacular ligament, and that's why we want to position the PIP joint in neutral, allowing DIP joint to flex. And then the purpose of this is not only to maintain the oblique retinacular ligament anatomical length, but also we know that when you flex the DIP joint, the lateral bands are pulled dorsal to the anatomical axis of rotation, and therefore by doing so, you are better approximating the central slip and the insertion point so that there is an adequate healing at this. So therefore, you are restoring the length tension relationship between extensors and flexors. Okay, so I'm reading the questions here. Okay, DIP upper extension splint as dorsal stack splint may cause compression to the dorsal skin, yes, and reduce the blood flow to the skin. So I think some of these questions are worth copying and pasting that, and so that we can answer. There are many questions pertaining to this, especially. So I think I'm going to copy this and save that on one of the documents, and then maybe we can post these questions on the website. Does that make sense?
Yeah, I think so. Okay. Can I jump in with a question?
Yeah, please go ahead.
Yeah. No, this question is to Kristen first. A little away from the topic. I mean, from your experience of making RMOs, when index finger or little finger is in question, do you experience difficulty in making a RMO as compared to middle and ring finger?
So I think in the presentation, I showed an image where, so say your index finger is the one injured, you need to include your small finger as well. So I think with anything, it takes some practice to make sure that you're fabricating things appropriately and really evaluating what you're doing. Little tips I think I've picked up on are make sure when you're cutting your thermoplastic, you need to taper it because obviously the distance with your small finger is much smaller than your index. You need to curve to match sort of where the heads of the metacarpals are. Often I will add some foam to the base of the splint just to extra ensure that you're maintaining that extension. But yeah, I think making sure you have that configuration appropriate is helpful. But it does take some practice in evaluating what you're doing to ensure you get that 15 to 20 degrees of a relative extension.
Okay. One more question, that is, in some of the images, I thought I saw that when in a fisted hand for zone 5 injury, this question is for Kristen again. In some of the images, I felt that the MCP was not flexing. So is there issues related to MCP extension contractures that you experience?
I think in the one video, you could see that the patient wasn't just told to make a fist. They were given sort of intrinsic minus, intrinsic plus, as well as the fist as well. So I think some of it is just ensuring that you have proper patient education, that they're understanding their exercises as well.
But there is no concern related to the contractures, residual contractures?
Personally, I haven't really come across that much because you are progressing fairly quickly through the program. And I think Merit as well showed around the 6 weeks, most of their patients had full range of motion regardless. So that doesn't typically tend to be a significant issue.
Okay, thank you. This last couple of questions for Shrikant sir.
Yes.
The first one is, I just wanted to know now for the EDC at the point of insertion at the base of the proximal phalanx, I mean, just before it divides into the slips, central as well as the lateral slips, the force traveling till that point, to what extent the force travels beyond that point after insertion?
Okay, so if you look at some of the diagrams, especially you'll see it's posted in the DP Green's surgical anatomy of the hand. So if you look at the extensor tendon, there's a slip that is connecting to the base of the fifth, right? So the base of the proximal phalanx.
Yeah.
There's a slip that is inserting on the base of the proximal phalanx, and then the tendon continues and then forms a central slip that inserts at the base of the middle phalanx. And then the lateral bands continue and then insert at the base of the distal phalanx, right? If you look at the orientation of your insertion slip that is inserting at the base of the proximal phalanx, so it is when you're flexing the finger, that slip is taut. Are you with me? So that slip is taut, and then when you extend the finger, then this slip that is at the base of the proximal phalanx will recoil proximally because of the pull of the extensor digitorum communis, and there'll be a continuation of the central slip load at the base of the middle phalanx, and then continuation of this the load on the lateral band that is inserting on the distal phalanx. So the insertion, the slip that is inserting at the base of the proximal phalanx is designed in a way that it becomes taut at certain point, but still the extensor tendon continuously has an excursion producing load at the base of the middle phalanx and then subsequently at the distal phalanx.
So does it carry the similar load distally, or because otherwise it is the intrinsics that provides the motor to the to the distal component of the extensor tendon?
So if you look at some of the fibers I showed you, they are primarily responsible for connecting to the medial band. And then there are some fibers that are connecting to the lateral bands of the extensor digitorum communis, right? So after the excursion of the base of the slip that is inserting on the proximal phalanx has reached its optimum, then the fibers, oblique fibers that are connecting to the medial band are transmitting forces at the base of the middle phalanx, causing middle phalanx to come into extension. And there are further, even more oblique fibers that are connecting to the lateral bands. And these lateral bands, are then, as you're involving your extensor digitorum communis, as the lateral bands are pulled more proximally, your intrinsic muscles are producing a slip at the conjoined lateral bands, creating a tension on the distal phalanx, causing a distal phalanx to extend as well. Right? Can you see my point?
Yes.
Yeah.
Thank you.
So there's a whole. I mean, I can probably write the whole entire 5-page chapter on mechanism of digital extension. And then, that by drawing those vector diagrams, I can show you as to how the excursion takes place at base of the proximal phalanx, how the excursion takes place at the base of the middle phalanx, and then finally the distal phalanx.
Yeah, it is an enigma.
Yes. So extensor digitorum communis primarily is an extensor of the metacarpophalangeal joint, and it is a weak extensor of the proximal as well as distal interphalangeal joint. So if we didn't have intrinsic fibers and those oblique and transverse and vertical fibers of the intrinsic at the extensor expansion, then probably we'll have a deficient extension of the PIP and DIP joint. So therefore, it is very essential for us to rehab all these fibers in a specific manner in order to maximize excursion of the central slip, giving you PIP joint extension. Then the oblique fibers giving extension of the terminal distal phalanx, and then continuously over the proximal phalanx. And the other thing is the metacarpophalangeal joint is not only based on excursion of extensor digitorum communis alone, but it is also contribution from the sagittal band, which causes pulling of the proximal phalanx into extension. Because if you take the sagittal bands off, you have an extensor life. Right, so the extensor tendon falls in an ulnar valley because that sling effect that you see, that lifting of the proximal phalanx into extension, is completely deficient.
Yes, thank you.
Thanks.
Yes, Dr. Jose, are we continuing with, or we move on to the next speaker?
I think given the time right now, I think we should continue with the next talk, so we can load the flexor tendon system, flexor tendon management. And I don't know whether you are able to copy all the questions. I think it will be interesting for us to copy all the questions and then post it, on the website.
Hello, everyone. My name is Juliana. I'm an occupational therapist and hand therapist at the Roth-McFarlane.
I hope you can listen.
Center in London, Canada. And it's my great pleasure to be here, invited by Shrikant on behalf of Dr. Jerome, to be talking to you about rehabilitation of flexor tendon injuries in zones 1 and 2. So the first thing every time I think of flexor tendon rehabilitation is how we evolved from not that long.
Dr. Shrikant, I think you can hear the video and audio.
I can hear the audio and video, yeah.
Thank you.
So about 80 years ago, from not moving or not repairing tendons at all, to then immobilizing them, to moving tendons actively, and even sometimes not even wearing a splint. How we went through this. So I'm just going to bring some key papers, just a few of them. There are hundreds of literature in flexor tendon rehabilitation, and can be quite overwhelming, but hopefully I'll just bring key ones, then we can summarize and then make sense as to how and why we do things the way we do nowadays. So prior to the 40s, nothing was repaired, and Mason and Allen realized or discovered that tendons actually did heal. So then they started being repaired, and it was believed that the healing was extrinsic, and therefore tendons were just immobilized. And it was not until in the mid-70s when Urbaniak, Drenhauser, and Kleinert, and a few other ones realized that tendons that were repaired and submitted to motion, they actually healed better and stronger. And therefore, we started moving as per the Rennhauser with the help of the other hand, passive motion, or with the help of the elastics like in the Kleiner protocol. And in the late 80s to early 90s, many authors, many clinicians and researchers across the globe started looking at wrist synergistic motion, so the effect of wrist motion, as well as the effect of just simple active motion in the repair tendon. And that's when we started moving tendons actively. So there's a paradigm shift, and we like to call it recent, but it's now been about 30 years that we use to move tendons passively. And the issue with moving tendons passively, so would be similar to threading a needle or putting the thread through the hole of the needle here. So you're pushing the tendon from distal to proximal. So there is a chance of the tendon folding up on itself, bunching up as opposed to actually gliding. Whereas when you have active motion, whether through synergistic wrist motion or actual through active motion, the tendon will now be moving from proximal to distal. So similar to as if we were using this little device here, to actually pull the thread through the hole of the needle. So it tends to be more effective and have a true glide, a true excursion. So here is a video that Dr. Lalonde was very kind to share with our group here, showing how the tendon bunches up on itself when you move the finger passively. So he did a passive motion and then place and hold. So let's watch this. So he's moving the repair tendon right here passively, and we see very minimal glide. You're pushing distal to proximal, and now he's going to ask the patient to actively do a place and hold, and you see that jerky pull through. So if you think now, when we do passive motion protocols and we institute place and hold, we can't really do that until later on, because the first few weeks we know that the repair tendon will actually become weaker before becoming stronger. So this amount of jerky motion here may pose some risk to the repair tendon in the early stages. So again, we see the tendon folding up on itself, and then it's going to get pulled through with active motion. So a few papers that I brought here, this is actually fairly old, just so we go through understanding how we went through this so-called evolution. So this is a study by Savage in 1985 with 24 subjects, and he looked at the amount of force exerted in fingers when they were extending using this gauge here on the fingernails, as well as the finger pulp, when he was looking into how much force there would be exerted with flexion. So he positioned subjects in 4 different positions: wrist extended, MCPs flexed; wrist in neutral, MCP flexed; here position 3, wrist flexed and MCP flexed; and here position 4, wrist flexed and MCP free. So he then created this graph here. So we have flexion force right there, and then extension force, and then each position will have 4 fingers, so index, middle, ring, and little. So position number 1, 2, 3, and 4. And what we see here is that position 1 is the one with the least amount of force exerted both in flexion and extension. Maybe not so much position 3 would have less force exerted in extension, but definitely that's acceptable when we don't need to worry about, because we have to worry about the flexor side. So back in 1985, we talked about positioning the wrist in extension, that would impose less tension on the flexor side, or less force traveling through the flexor side. Then when we looked at the first few studies talking about force versus repair, so the amount of force that can travel through a repair tendon, that study was done by Urbaniak and then redone in different, in a more updated version by Dr. Strickland and published in 2005, that he looked at the amount of forces traveling through the tendon or exerted through the tendon. And then here's the repair time. So time in weeks, so repair 1 week, 3 weeks, and 6. So we see here that 2-strand repair the force of the repair is situated right here, around 2,000 grams of force. A 4-strain repair is around 4 to 3 grams of force, and then we all see that tendency of the repair strength going down and then turning back up around 3 weeks. And then 6-strain repair between 6 and 5,000 grams. And then he reported that when patients were moving passively, this is the amount of force that would travel through the repair tendon. When doing light active, this is the amount of force that would travel through. And then strong grasp, this is the amount of force that would travel through the tendon. So then it was determined a few times over and over that the 4-strain repair could certainly overcome light active motion, as demonstrated here. So the threshold is well above the amount of force exerted in light active motion. And there has been a series of studies done by Dr. Peter M.Th.O and his group at the Mayo Clinic, and they basically looked at many different situations at synergistic, the effect of synergistic wrist motion and the amount of forces that traveled through repaired tendons. So they first determined, using this little gauge here, and submitting a repair tendon to opposing forces to see what's the gapping point, what's the threshold for gapping at a repair tendon, and that was determined to be 7 newtons. So then every therapist, what do we want, or surgeons? We want the maximum amount of excursion with the minimum amount of load traveling through the tendon. Okay, so he had determined that synergistic wrist motion has less tension as opposed to holding the wrist flexed or extended. He had done that in other papers. And on this paper here, he specifically looked at 4 different positions. So wrist completely flexed while the finger was extended, looking at the strain through the FDP. Then we have wrist flexed, fingers flexed, wrist extended, fingers flexed, wrist extended, and MCPs extended. So what then happened? So we will see that in position C, and here we have this graph here. So here's the position of the MCP joint, all the way from 90 degrees to flexion to complete extension, and then forces in Newton right here. So he had determined that the gapping point was 7 newtons, so above, out of the graph. So position C, for instance, with the MCP at about 60 degrees, there's no tension through the repaired site. Whereas position D, this one right here, in which the MCP was extended right there, we will see that the amount of stress that goes through or the force that travels through the repaired tendon is about 1.77 newtons of force, meaning that it still is below the 7 newtons threshold for gapping the tendon. Again, how does this help rehabilitation? If we think of what we want to do as therapists for our flexor tendon patients is that we want to decrease the work of force, meaning that any forces or conditions that will impose that more tension through the flexor side. So for instance, if I hold the wrist, like we used to believe that holding the wrist flexed detension the flexor tendon is true, but when I try to move actively, I actually get the tension of my extensor tendon, so that increases my work of flexion. And then if I have very thick scarring, even superficially, or problems with healing the hissing wound, edema, that will also increase the work of flexion. So our goal as therapists is to try and do the best that we can to overcome that. And the reason as to why I brought this here is that we feel very comfortable going to this wrist extension and fingers flexed. We're not so comfortable with extending the MCP joint. And that's a beautiful position because patients will be held in this position for so long that the intrinsic muscles can become tight. And therefore, having the opportunity to go to intrinsic minus, it will stretch the intrinsic muscles and subsequently decrease the work of flexion, because that would be one more thing to increase the work of flexion. Here is one of the earliest studies that I came across looking specifically at true active motion of repaired tendons. So this was a study done in 1987 by Hitchcock and colleagues in 216 chicken. So what they did is they separated chicken. It was randomized into two groups, one that was completely immobilized. So they cut the middle finger off the chicken and repaired, and this one was immobilized, one group. And the other group had the two adjacent fingers held in more extension and detension, and the chicken were allowed to walk freely. So the chicken would actually be putting a lot of tension through the repaired tendon. So we have here mean rupture strength, meaning that the higher the better. And then here's days from 0 to 40. So we see that the immobilized ones are the ones with the dark symbols. We see that the strength actually goes down and then slightly up after around 3 weeks, but still well below the constrained group or the active group. So we see that this one actually keeps on going down every week or every day, meaning that it's a lot stronger. So where do we stand today? Where are we in 2021 when we talk about flexor tendon rehabilitation? So I'd like to tell you we have basically three main groups of rehabilitation. Tendons can still nowadays be immobilized, and we'll go over it in a little bit more detail for whatever reason. So patients will be immobilized for 3 to 4 weeks. The tendons can also be moved passively, and that will be either moving the tendon with the other hand or with the help of the elastics, or there's a category of early active motion. So we have immobilization, early passive, and early active motion. Early active motion, any form of wrist motion, true mid-range active motion, or combination of both. So now looking more specifically at the different protocols or guidelines, when do we mobilize tendons? Do we still use immobilization as a way of treating patients? Yes, we do. And that would be resorted to very young patients, so children for the most part, patients that are cognitively unable to collaborate with the program, such as people with moderate to severe dementia, or people that have been affected through a car accident or some sort of accident that they had the brain injury. So we will resort to immobilizing the tendon at that point in time. We normally immobilize for 3 to 4 weeks, and then we place patients in a splint and start removing the splint for exercises, both active and passive, and engage in resistance activities around 8 weeks or so. We also still use passive range of motion protocol or early passive protocols, and that's reserved for repairs that we believe they can withstand some motion. Patients can collaborate, but they're not very strong for whatever reason. So it could be the repair was done under a lot of tension, or the tendon had to be trimmed, or there's significant infection, a lot of swelling, a lot of wound dehiscence. So we need to be mindful of that. We may be resorting to using immobilization protocol. So what we do, and that's probably the most widely used worldwide, is just to modify Duran exercise, which is passive composite flexion within the confines of the splint and active extension within the confines of the splint. We used to believe the wrist had to be held in flexion, and I think we have enough information now, as I just demonstrated the couple earlier on, and we have even other papers I'm happy to share with you, that maintaining the wrist in flexion actually also increases the work of flexion. And then they move into intermediate stage, in which they do a place and hold, similar to what we saw in Dr. Donnell's video. So patients will passively flex the fingers and then actively try and maintain that fist. And that happens until about 6 weeks. The splint is discontinued for light activities. And then around 8 weeks, patients will start engaging in more resistant activities. So when we think about how we evolve through these protocols. So how do we call these guidelines and not protocols? When you think protocols, we think of being married 2 weeks. So you won't move to week 3 if you think that, week 2 is not done. And that's not the case. Roth in 2004, she published this beautiful work that she called the Pyramid of Progressive Force Application. So we always start at the base and then we move up, and then we have a few exercises that are done with the wrist protected. So that would be probably the first 5 to 6 weeks. And then when we start moving with the wrist unprotected. So we go from passive motion to place and hold to active and to isolated motion. For the current protocols in which people are moving actively, I think we can still use this pyramid, but we have to modify it just slightly at the base. So perhaps we have more of a squared base and then it becomes a pyramid. So I suggested that we change this to so we would do passive motion, synergistic wrist motion, and active mid-range flexion, all forming the base of the pyramid, but still that same concept. And what kind of early active mobilization protocol or guidelines do we have in 2021 that we still use? So the synergistic wrist motion that became known as the Indiana Protocol by Dr. Strickland and Nancy Cannon in 1993. I do not believe now people have incorporated that onto other protocols or guidelines, but I don't believe this works as a standalone only. I don't believe that's happening anymore. Again, I have not done research about this, so this is more from me talking to different therapists and observing what's being presented or discussed in different groups. So I don't believe this is working as a standalone program. But the point of this that I brought here is just so we understand what synergistic wrist motion initially was described using a hinged brace. The wrist was actively extended and the fingers passively flexed, and then patients actively held the fingers in that position, and then the wrist was actively flexed and the fingers extended within the confines of the splint. The one that's probably the most popular early active protocol is the one that was initially described by Dr. Jim Boateng in 2007. Initially, the wrist was held in flexion. Patients would do what we call warm-up exercises, which is similar to the Hauser, passive flexion, active extension within the confines of the splint. After 2.5 weeks, patients were placed with the wrist in extension, and all throughout this, patients were moving mid-range active flexion and extension within the confines of the splint. He has since changed, so he has done a series of studies and publications in which he now states that the wrist position doesn't really matter. It's not as important as perhaps he had thought in the past. So he's perfectly fine with wrist being placed in neutral or a little bit more extension. And he has even talked about doing repairs with a little bit of a tightening to create a bit of a bulk mid-tension, as he mentioned. So the tendons are no longer repaired flush. They have a bit of a tension through the repair sites. And what that does, it provides the tendon with a little more strength and allowing for better active range of motion. And because of this, he suggested bending the pulleys. Probably the most trendy protocol or guideline is the St. John protocol that was well outlined by Dr. Lalonde and Amanda Higgins in 2016. The indication would be for patients with at least 4 strand repairs, and the surgeries were done wide awake. So the surgeon and the therapist could make sure that there's no gapping in the tendon. And as such, what they did is the wrist was positioned in slight extension and the MCP joints in about 30 degrees of flexion. And movement would start between 3 and 5 days. And it would start off with warm-up exercises, so similar to a Duran and Hauser passive flexion, active extension within the confines of the splint, and mid-range active flexion with the forearm-based dorsal walking splint for the first 2 weeks. And then after 2 weeks, patients would transition to a Th.O, this is short hand-based splint. So I'll show you posted a video or videos with this particular paper. So I just thought I would bring here. So this is a patient around 2 weeks in the short Manchester orthosis. And then patients were moving passively initially, and then they would move actively. Another program that I believe, at least not in North America, is as popularized, and it's called the Manchester Protocol. It was described by Juliana and Dr. Peck in 2013. So the wrist is positioned in slight extension, as demonstrated here, and patients will move through mid-arc active flexion, and then around 2 weeks or so, they will transition. But then they have since just started placing patients right away on the short splint, as demonstrated right here, in which the wrist is free, as well as allowing patients to use the hand for light activities. And then one thing that I became really curious about was how come that they can do that, right? What is it that it makes it different, that patients are allowed not only to be in the short splint, but allowed to use the hand for light activities? My only explanation, and then I know that most of the audience is composed of hand surgeons, so I will probably place this question back to you, but my only explanation was I learned that their stitch is a dynamic suture. So if we follow here, it would enter through here, go 1 centimeter into the tendon, and then half a centimeter on the other side, and then half a centimeter on the side that it was first done, and then 1 centimeter on the opposite side, and so it's a one running suture with the 4-strand repair. And so when the tendons are pulled in opposing directions here, it would make it so that the middle part, the middle stitch, part of the stitch, would actually pull and bring the end of the tendons together. So when, again, we think of early active motion, what else is there? So there had been some reports of patients not wearing wrist braces, as described in a few protocols or by a few groups. And so I found this systematic review looking at 5 studies in which the patients would not be wearing a splint. They were rehabilitated without this brace. So what they concluded was that they couldn't really tell which one was better, with or without a splint. So we're not quite there yet. Another way that some people have described, and I just brought here one article by Henry and Juliana last year in 2020. They did a retrospective study of 10 cases, and basically they placed the patients in the wrist cock-up with a relative motion splint, holding the affected finger in slight more flexion relative to the other fingers. So what they found out is that, and then again, the follow-up was a little bit all over the place, so not as equal, but what they found out is that most patients had either excellent or good total active range of motion. So as we see here, this is the amount of BIP flexion, and this is the amount of VIP flexion, so a pretty decent result. So there's also another study looking at 51 patients retrospectively, looking at active finger mobilization, meaning that patients were actually not wearing a splint. Yes, you did hear it right. They were not wearing a splint. So you may go like, wait a second, not wearing a splint, is that right? So then I, again, went digging on that study a little bit to understand why. So the study design said that the patients were provided with a splint, and they were instructed to wear the splint during specific risk environments. So would work, for instance, if I work in construction, would work be included in that? And therefore, would I be in my splint for 8 hours? Somewhat similar to just wearing a splint altogether. So I found that was not so clear. Patients were instructed in this particular study to move through tendon gliding positions. And then here we have the report of the 51 patients. At 3 weeks post-op, 6 and 10 to 12. Here's PIP extension, so pretty decent, pretty close to 0. PIP flexion at 93 at 3 weeks. DIP extension pretty decent again, around 0. And then DIP flexion between 45 and 50, especially at the 10 to 12 week mark. One thing, though, that I always go back, as I said, is what frequency were people really wearing splint? That was never clear. So if they were fearful, could they be wearing a splint? Again, that was not very clear, because the outcomes could definitely be different if they added that. And also the type of repair. That's probably not doable with every repair. So that was also not clear what type it was done. And now looking at evidence specifically, looking at tendons that are repaired and treated via immobilized, early active motion would be this one here, or early passive motion. So Dr. Trumbull and colleagues in 2010 published that patients were randomly assigned to these two groups. So we had 61 in the early active and 55 in the early passive motion. And what we can see here is that at 12 weeks, so here's the active group and the passive group. So the active group at 12 weeks had about 137, and we wanted to be close to 270 for all three joints, 90, 90, and 90. And then we see that at 52 weeks, the early active group was still ahead of schedule in relationship to the passive group. Another study, now not a randomized controlled trial, but a retrospective study looking at 159 digits, looked at comparing early passive motion versus controlled active motion, so through mid-arc flexion. So we see here we have total active motion, so the higher the better, and then we have the active group and the passive group. So we see that at week 4, the active group is much higher, the median, the middle of their case series. We see it's much higher than the passive motion group. So the question that we may ask ourselves, are we facing another paradigm shift in which we may not be wearing a splint? Are we facing that? My answer to you is we're not done with this paradigm shift, but we are certainly transitioning. So I believe that in a few years from now, if I give this lecture again, it will be very different than what it does nowadays, because flexor tendon is constantly evolving. So in summary is we have evidence to say that early active motion is very safe, even if the repair isn't very strong. We learned that even weak repairs can withstand the risk in neutral or more extension because it actually decreases the work of flexion. Better range of motion outcomes we have with early active motion and faster return to pre-injury activities. What we don't have very high evidence, or we have very low evidence, is no risk in orthosis. So we are not there yet, 100%. The use of relative motion orthosis, I don't think we are there yet with respect to evidence, or not wearing a splint at all. So what do we do at the Roth-McFarlane Hand and Microsurgery Center? We are fortunate enough to have Shrikant Chinchalkar as our great mentor and founder of our department. So Shrikant brought the idea of combining synergistic wrist motion and early active motion, as has been described by other authors. And what we did slightly different is a few things is obviously very, very similar to everybody else. We divided our protocol into 3 phases, so we'll cover them in a little more detail, and it was recommended for 4-strand repair or 2-strand repair with epitendinous suture because that gives the repair strength of 1 more coarse suture. And then we start off by positioning our patients in the dorsal blocking splint with the wrist in slight extension at 30 degrees, MCPs at 60, and then IP joints fully straight. And we are very adamant about holding that to prevent complications that can happen. And hopefully one day we can talk here about complications in flexor tendon rehabilitation, but for now we will really talk about that very important position. So we start off by doing warm-up exercises, passive composite flexion and active extension within the confines of the splint. That's the first exercise. The second exercise is synergistic wrist motion, but as described by the group of Dr. Peter M.Th.O at the Mayo Clinic, in which we learned, and I showed just one of their studies here, patients, cadavers going from full flexion to basically that position. So we'll see one example here. The patient just went to full composite flexion. But we will see that it's very safe. So that confers the highest amount of excursion with the least amount of load. And we have learned that through many papers before. So I guide patients to move very slowly, very gently. I tell them this is like dancing ballet. You're doing this very, refined. So there's no jerky motion. There's not a lot of tension. And we see full wrist flexion, full finger extension, active wrist extension, and then active assisted passive finger flexion. Then we also do sometimes with very specific patients that they do not have a lot of complications leading to increased work of flexion. We will resort to this, as I explained, not because Tanaka in 2005 and his colleagues said that this position here imposes 1.77 newtons of force through the repair tendon, but they did that in cadavers. Cadavers had no swelling, no sutures, no dressing, so we can't really just transfer that. But if we have the right patient, we will resort to that position because that confers us the ability to get into intrinsic minus and stretch our intrinsics, because patients will be in intrinsic plus position, so intrinsic muscles can become fairly tight and therefore increases the work of flexion. So we will do that, and I have an example here of a patient. I'm not the greatest videographer, so I apologize for my skills here, not the best. Again, guiding the patients, walking them through full wrist extension, and then fingers with MCP extended. Again, we do very few of those. When we feel comfortable, I think we need to study more, and that has not been very studied, but we have enough evidence to do that with certain patients that have very low conditions that would increase the work of flexion. And the third exercise is active mid-range flexion within the confines of the splint and active extension to the dorsal blocking splint. So we try to go through the technique that patients will be flexing to 3 fingers, then 2 fingers, then 1 finger, and then eventually no fingers. So we evolved through that throughout the weeks. But we like to use this finger scratch technique that was described by Pentagill and Van Strain in 2014, in which patients will touch 4 fingers, for instance, and then slide to 2 or to 3 fingers and extend. So we go touch the top, slide to the next, and extend. When we're dealing with the little finger, because of the length, we just actually move to 2 fingers automatically, because otherwise it will not be mid-arc flexion. And that was the situation here with this patient. So she's touching 3 fingers, glide to 2, and full extension. And here's another example of a patient doing the finger scratch technique and in the video. So a little finger, so he's going to try to aim the second finger. This is 5 days post-operatively, his first hand therapy visit. So again, touch 3 fingers, glide to 2, and back in extension.
I think you can advance it a bit and then we begin again.
8 to 10 weeks. 8 for the ones that are showing great signs of scarring, and 10 for the ones that are moving okay. So here are some results. So here is zone 1, little finger at 6 weeks, little finger at 8 weeks. Here is patient of mine, she had some early adhesions and early on. So here's her at 14 weeks, little finger. And again, there was zone 1 here. And a zone 2. This is one of Shrikant's patients. I don't always remember to take videos, so I'm very grateful for Shrikant and his generosity in sharing his videos with us. Here, so excellent result at 6 weeks for zone 2. Here, same thing, patient with FDS, FDP, and radial digital nerve at 12 weeks. Again, excellent result. And here's little finger at 12 weeks. Better. So it's very hard. We definitely have a whole lot more than just 11 patients, but I just was able to compile these patients here that we have been using these techniques for the past 5 years or so. So in average, our patients will attend hand therapy between 3 and 4 months total from date of surgery to date of discharge. Most of them are males. And here we have patients 1 to 11, 14 fingers in total. So PIP extension and flexion. So we see extension in average is almost 0 and flexion is 97. And here's DIP again. Extension is almost 0 and flexion is 58. So take home message from my talk here is that protocols or guidelines should be chosen based on the patient, on stages of healing and quality of repair, work of flexion, the amount of stress you're putting through the repair tendon. So taking all of that in consideration. Whenever possible, early active is definitely the way to go. And it seems like combining synergistic wrist motion and true active motion is even better. If passive range of motion is greater than active, maybe you should fast forward following that pyramid of growth. If passive and active motion is somewhat the same, so maybe we'll slow down or like call tag along. So you sort of don't need to push things too quickly. Two-strand repair is probably very suitable to do early active motion, especially if there is epitendinous suture and there's no need to hold the wrist in flexion, so we can bring into neutral at least. And keep close communication if you're a therapist in the audience. Keep close communication with your physician so you get more information. And physicians, please let your therapist know the quality of repair, if there is any chance of gapping, if you had to trim, if that repair was done under tension. That's the information we need to know to help your patients better. And close monitoring of secondary complications. So we didn't cover that today, but I'd like to say that treat complications before they become a real problem. Deal with problems before they're actually problems. I'd like to say special thank you to Shrikant and Chinchalkar for his mentorship and friendship. And then my colleagues at the Roth-McFarlane Hand and Microsurgery Center. This is when we could get together. And thank to all of you that have been here, I guess for the past 30 minutes or so listening to my presentation. Here's my email if you want to take note. And I'd be happy to talk to you and discuss anything or any questions that you may have. And my son just reading Greece offering notes. So thank you.
I think, thank you, Juliana, for this, incredible and fabulous talk on a very vital topic on flexor rehabilitations. I think we'll take a couple of quick questions and then probably we can wind up the session.
Okay. Are there any questions?
I think there are no more questions. We will have a quick 10 seconds closing remark from Shrikant, Kristen, and Rokshovan, and then we'll wind up the session.
Okay, so I'll begin. So thank you very much for attending and being part of the today's session. And I thank especially Dr. Terence Jerome for including us in this talk, because therapy is very important, especially when you're treating upper limb injuries. And we are like surgeons' backbones. We call ourselves your backbones because your success is dependent on our hands. So thank you very much for including us. It's a great pleasure and honor to be with the group, with Journal of Hand and Microsurgery. Thank you.
Thank you very much. Dr. Kristen?
I would just echo Shrikant's remarks there and just thank you for the opportunity to be part of this today, and hope that the information was some value for the participants. And we are open to emailing and that sort of thing if people did have further questions or points of discussion to carry on these conversations. Thank you.
Thank you. Dr. Sean?
Yeah, thank you at the outset, Dr. Jose, for the wonderful opportunity. I really enjoyed moderating the sessions from these eminent speakers. And thank you all the participants to be here and attending these master classes. So we hope to see you again on some other topic of interest. Thank you.
Thank you, viewers, and thank you, the panelists, Dr. Shrikant, Kristen, and Dr. Sean for this wonderful event. You have made it a great event. Thank you all. Wish you all safe and healthy at this juncture. Hope to meet you all soon. Thank you very much.